Thank you again for joining us for today's webinar, Risk Sharing Agreements in the U.S., Trends, Barriers, and Prospects. I will now turn it over to our moderator.
Good morning. I'm Kimberly Westrich, Vice President for Health Services Research at the National Pharmaceutical Council. We're glad you could join us today. We are going to spend the next hour discussing trends in risk-sharing agreements in the United States, barriers to wider adoption, and prospects for overcoming those barriers. We have a great group of speakers with us today who I'd like to briefly introduce. Dr. Lou Garrison has 2 roles at the University of Washington. He's a professor of Pharmaceutical Outcomes Research and Policy program in the School of Pharmacy. He's also an adjunct professor in the Departments of Global Health and Health Services. He also co-directs the Global Medicine Program in Global Health, and he is the president-elect of ISPOR, the International Society for Pharmacoeconomics and Outcomes Research. Dr. Josh Carlson also has 2 roles at the University of Washington. He's an assistant professor in the Pharmaceutical Outcomes Research and Policy program. He's also an affiliate faculty member at the Fred Hutchinson Cancer Research Center. And Ed Pizzala is also with us today. He is the Vice President of Pharmaceutical Policy and Strategy at Aetna, and he's responsible for the integration of pharmacy policy and activities into Aetna's overall strategy and operations. So risk-sharing agreements are very much in the news today. They've been limited to date in the U.S., but as we're moving from volume to value, there's a great deal of interest in them. Earlier this month, an agreement was announced between Amgen and Harvard Pilgrim that focuses on utilization and outcomes from Wrapup. Later this week, another activity related to risk-sharing agreements, the Department of Health and Human Services will be holding a forum that focuses on innovation, access, affordability, and better health, and one of the topics on the agenda is risk-sharing agreements. So why is there so much interest in risk-sharing agreements? Well, potentially they can be win-win for all stakeholders. By linking coverage or reimbursement to the actual drug performance or utilization, payers can reduce their risk of uncertainty, the financial impact of a new product. Manufacturers can demonstrate the value of their new product. Consumers potentially gain earlier access to treatments, and society continues to make the important move towards value-based purchasing. So the focus of today's webinar will be a study that we recently published in the American Journal of Managed Care. It was a joint study conducted by experts from the National Pharmaceutical Council, University of Washington, Tufts University, and the Office of Health Economics. The speakers will go into greater detail on the study, but basically what did we find? We found that there is not a lot of risk-sharing agreement activity in the U.S. today, but there's a great deal of interest among payers and manufacturers. Right now there's a lot of barriers out there that are preventing more prevalent risk-sharing agreements, but as the environment continues to change, we hope that there's the potential, or we think there's the potential, for more risk-sharing agreements in the U.S. So the study has 4 basic components. Dr. Carlson will be covering the first 2, talking about a database review of the University of Washington's Performance-Based Risk-Sharing Agreements database, what we're seeing in that database, how prevalent these agreements are here in the U.S. and abroad. There'll be a literature review or a presentation of taxonomies. There's all sorts of different terms used for risk-sharing agreements, and it's always helpful to get that level setting. And he'll also be kind of providing an overview of the landscape. Then Dr. Garrison will talk about interviews that we conducted with the key stakeholders, what they said, and an online survey that we conducted to follow up on those interviews to delve a little bit more deeply into the barriers that people are seeing. And Dr. Pizzala will react to the study. And with that, I'd like to turn it over to Dr. Carlson. Josh?
Great, thank you, Kimberly. I've already been introduced, so we can move on to the next slide. Thanks. As Kimberly was mentioning, there are a number of terms that are used to describe these types of agreements. We use the term performance-based risk-sharing arrangements, but as you can see from this list, there are a number of arrangements. So we will usually use the term performance-based risk-sharing arrangements. We might also use the term risk-sharing agreements, etc. And the name that's used is dependent somewhat on the country or the health system in which the specific type of arrangement is being used and has been used historically. So we can go on to the next slide. So the key components of performance-based risk-sharing agreements are, first and foremost, that there is a program of data collection. So this can either be a public level type of data collection, or this can just be an agreement between two parties in a private manner to collect data. That data collection program is also is initiated at the time of negotiation. So the key component here also is that we are looking forward in time. This program of data collection starts at the agreement launch and moves forward over time, and then the results of that data collection period are then linked either directly or indirectly to the price, reimbursement, or the revenue that comes that is exchanged between the groups that are in the negotiation. It's basically underlying this program of data collection is the fact that there's an uncertainty that needs to be addressed. So this uncertainty can take many forms. With these types of agreements in medical products, they are often around outcomes, but they can also be around the finances that are part of paying for and reimbursing medical products. And where the term risk-sharing agreement comes about is that there's basically a different distribution of risk that gets established versus what would be the traditional distribution of risk. And this comes because traditionally agreements to pay for and reimburse medical products were looking backwards. They looked back at what the evidence was when the product came to market, and basically there was a price set, and everybody moved forward with a certain amount with a certain distribution of risk. With a program of data collection that looks forward, that distribution of risk changes depending on the outcomes that are being measured and the program of data collection itself. So there's just a difference in the distribution of risk moving forward. So those are the key elements. We can move forward to the next slide. So I'm going to provide a quick overview. This is data that comes from our database here at the University of Washington, which we've maintained since 2009. And this just looks at the number of cases that we've found over time. The blue bars are the cumulative number of cases, and the red bars are by year. And you can see by the red bars, there's basically the enthusiasm peaked in around 2007, and it's basically fluctuated, up or down a little bit, but we've seen some in every year. We usually have a little bit of a lag in the current year ability to find and track these types of agreements. This says the total schemes here are 292. I think we're even up a little bit higher over the past month. This data is from October. We can move on to the next slide. This shows the number of performance-based schemes by country, and the number one country in terms of these schemes has been Italy. They continue to go strong with these. Most of them are in the area of cancer, and many across the border in the area of cancer. But we also see Sweden being highly involved, Australia, the United States, is involved. Countries like Sweden, the United States, and the Netherlands, a lot of the agreements that we see are actually of the coverage with evidence development variety, which I will describe in more detail coming up. But you can see that there are a number of countries that are involved in these types of agreements, and the ones further to the left are ones that are perhaps experimenting with them a little bit, or are just seeing if they can make it work for their own jurisdictions. Okay, we can move on to the next slide. This is the taxonomy that we created back in 2010, and there have been other taxonomies that have been derivative of this original taxonomy, and they all operate on essentially two key components. That is the measure that's being used as within the program of data collection. That is whether it's a health outcomes measure or if it's more of a financial or utilization-based measure. and then whether the scheme or the agreement operates on the patient level or the population level. But our taxonomy is broken into here, non-outcomes-based schemes, that's the ones that rely on financial or utilization-based measures, and the health outcomes-based schemes on the right there. Our original review actually only focused on the health outcomes side of things, but nowadays we try and capture both of those. But we do kind of stay away from the more traditional agreements, which are price volume and market share level agreements. Within this, we have basically conditional coverage. Under that, we have the main category there being the coverage with evidence development variety. And there's two different types there. There's only in research, that is whereby the product is covered if patients are actively participating in research. And then we have only with research variety, and that is where all of the members of a given health system or payer group are covered, but the program of data collection or the program of research is only on a subset of those members. So there's two different varieties there. But the key component here with coverage with evidence development is that this is not about the amount of money that changes hands. This is focusing on just whether or not the product is covered for a given membership. To the right of that, we have conditional treatment continuation. This is essentially akin to a stopping rule that we might have in the clinical setting. Essentially, with conditional treatment continuation, it's akin to a stopping rule whereby there's a measure of effectiveness. Once a certain amount of time has passed that's agreed upon within the agreement, there's a measure of effectiveness, and if the patient is seen to be benefiting, then they can go on and receive additional medical product, and that's covered. But if they're not benefiting, then coverage for that product is stopped. We often see this in the area of cancer where we have perhaps response rates that are checked after 4 cycles or 2 months. If the patient's responding, they can go on and receive additional product, and that's covered. And if they're not, then they're going to be stopping product, and it's not going to be covered moving forward. Again, this is just whether it's covered or not. It doesn't have to do with the exact amount of money that's changing hands. Over to the right, we have performance-linked reimbursement. This is where we have a lot of the enthusiasm. This is the area where we have outcomes guarantees. So in the example I just gave with cancer, this would be if the patient is responding, then they can receive additional product. But if they're not responding, not only do they not get additional drug, but the manufacturer has to pay back the payer for the amount of drug that was used in that patient to begin with. And there's a number of varieties that happen there, and that's where a lot of the interest is these days. Okay, so that's the basic taxonomy, and we can move forward from there. So what I thought would be interesting would be go through a couple U.S. cases that I think highlight some of the key points about what's attractive with these and also how involved they can be. So the first case that I'll speak about is Januvia and Janimet. Those are Merck products, and Cigna, and these are in the area of diabetes. And this has components to it. So as I mentioned, these can get rather involved. But Cigna assesses the blood sugar levels for patients on any oral anti-diabetic medication. That is essentially not just Januvia and Janimet, it's anybody on anti-diabetic medications. And if in aggregate the A1C values improve by the end of the agreement period, discounts were going to be increased by a pre-specified amount. So if patients do better, there's an increased discount. The second level is that Cigna uses claims data to determine if patients are taking their medications as prescribed. This is an adherence measure. If patients are more adherent, then there's an increased discount as well. So we're getting an increased discount for adherent patients. Finally, for this, there's better placement on Cigna's formulary and a lower copayment versus that of other branded drugs. So Merck's products get a better position in the formulary. And so with this, we get a win-win-win. We essentially get a situation where Cigna has a number of opportunities to get additional discounts on products. Patients are getting, there's an incentive by all parties to have patients be more adherent to their drugs, and with increased adherence, we have better outcomes with diabetes. There's also potentially, with increased adherence, to have fewer disease-related sequelae like hospitalizations, etc. So there's a benefit for patients there. And then finally, Merck gets a better position on the formulary and a competitive advantage versus their products in a very competitive space. So we see a win-win-win in this scenario. We can move on. And so they did an evaluation, and we actually don't see this very often, and they were able to provide the results of some of this. And basically, it was a positive result. Patients' blood sugar levels were reduced by more than 5%, and they were more likely to have their blood sugar controlled, and adherence remained high and actually improved during this period. And so there was some quotes here I have at the bottom just essentially saying that this program was successful, and it was set up in a way that provided the potential for a win-win-win for all parties involved. We can move on to the next example. This one is Resondronate, an agreement that they had with Health Alliance in the area of osteoporosis. And this one is actually focused on addressing uncertainty. I think this does a really good job of highlighting that as one of the key reasons for doing these types of agreements. But essentially, the clinical trial for Resondronate failed to show a statistically significant reduction in non-spinal fractures, whereas some of its competitors had shown that impact in a statistically significant way. And so there was uncertainty about the impact of this product on non-spinal fractures. So the two companies agreed to essentially reimburse the insurer. The manufacturer agreed to reimburse the insurer for the cost of treating non-spinal fractures for patients who were adherent to their medications. So there is an adherence component. They did want to make sure that patients were actually taking their drugs sufficiently, but in that case, they were willing to essentially guarantee the cost of treating those non-spinal fractures. So this is the first example we saw where the manufacturer was agreeing to cover the cost of the disease-related sequelae as opposed to just a discount or refunding the cost of their product. That is, they were willing to take on the cost exposure of the outcome that their drug was supposed to reduce and avoid, that is, the non-spinal fractures. And these were non-trivial. Hip and wrist fractures cost approximately $30,000 to $6,000 respectively. Okay, so we can move on. Okay, so they did some results on this one as well, and basically the reimbursements that the manufacturer had to put forward as part of this agreement were almost 80% lower than the maximum outlined in the 8 months. So essentially, the outcomes were in line with what was shown in the trial, and there was not the manufacturer was not unduly exposed to the cost of covering those non-spinal fractures. And there's some very positive quotes here that I won't read verbatim, but from both the Health Alliance pharmacy director, but also another pharmacy director stating their enthusiasm for this type of agreement. I think one thing that's very interesting to note in this is when they were basically guaranteeing the outcome, the non-spinal fractures, they didn't have to discuss price or discount their price or have any of the issues that can come up with changing your list price or negotiating different prices. They essentially took that off the table and they focused on the uncertainty that was present with their product at launch. Okay, we can move on then. So just sort of summarizing the U.S., and on the right I have some more results, but you can see over time there has been some interest in the U.S. We have over 30 cases now. Now, many of these are of the coverage with evidence development variety through the Center for Medicare and Medicaid Services. And that program continues to be a viable option. We see more programs continuing to come online. A lot of those are focused on the device space, though not exclusively. And devices are a particularly interesting space for this, given that they come to market with a less developed evidence base than pharmaceuticals might. I also list the outcomes that we just went through with both Cigna and Januvia and Health Alliance and Actonel, those both being positive cases that where the reports were actually the results were actually made available. And we have seen other agreements with elements of this come through the pipe in the U.S. But by and large, we don't see a lot of volume. Now, in the U.S., there is always the issue that many of these, that there is the opportunity for private agreements that we cannot observe happening, and that's why we've gone to use other methods to try and find cases, that being interviews, et cetera, which we'll get into the second part of today's talk. But there is, the take home here is that there are cases in the U.S., there are some positive cases. There are challenges with them in their complexity and how we measure that, but they are doable. So we do see increased use over time, just not a lot of volume at this point. I can move on to the next slide. So just some take-home points before we go on to the next section, and something I didn't explicitly mention, but basically most of these types of agreements are going to be focused on high-cost disease areas and expensive drugs. That is, there's enough work involved to making them happen that you need enough money on the table to make all that effort worthwhile to both parties. CED is a good mechanism to compel additional data generation and resolve existing uncertainty, and we see that in the U.S. primarily in the Center for Medicare and Medicaid Services program, and a lot of that, or a good portion of that, is focused on the device space, but not exclusively. There is the potential for successful arrangements that can benefit payers, manufacturers, and patients. We saw that with the Januvia and Janimed example. Their agreements should address an agreed-upon uncertainty. That was pretty clear with the Actonel example, focusing on non-spinal fractures, this specific area of uncertainty that was revealed during their clinical trial program. Also, arrangements can link diseases and treatment, basically these agreements to treatment-related costs and disease-related costs, and that's one convenient mechanism to avoid issues related to changing list prices and drug prices. And there are a number of issues that come up when you're focusing on price. And a key component to all of this is arrangements should try and leverage existing data systems when possible. A lot of these have an adherence program in the U.S., and that's a key component because that is something that is can be measured with claims and something that manufacturers and health plans are used to measuring. So given the amount of administrative burden that's possible with these, existing systems should be leveraged whenever possible. And so with that, I will wrap up my overview of the U.S. and turn it over to Lou to focus on the next part of the program.
Thank you, everybody, for their interest. We really appreciate this level of interest. And I also want to thank the National Pharmaceutical Council for supporting this research. As Josh mentioned, this goes back a ways. We started this project really in 2007. You may recall that when the UK launched one of the first risk agreements around Velcade, it was an article in the New York Times. So I think we were actually thinking of it about the same time, but it was clear it was an issue that's going to keep coming up. I also, besides thanking the National Pharmaceutical Council, I want to thank our co-authors on the paper. Kimberly read the institutions, but we've been working with Preeti Bajaj, Adrian Taus, Peter Newman, Sean Sullivan, and then our colleagues at NPC on this project. But the other group we've been working at since 2007. Josh and I have taught a course at ISPOR for the last 5 years, and we've had over 1,500 participants, and most recently in Milan we had over 150 participants, very few from the U.S. So it's not just an issue for the U.S., even though that's what we're focusing on in this particular study. Kimberly mentioned this as thinking of this broadly as in the part of the movement from volume to value. I think the other trend that we're seeing in companies and at the ISPOR meeting is a great interest in real-world evidence. So you can think of this, as Josh said, as collecting data after launch. So what's happening on products in the real world? Products are launched in a situation of uncertainty and risk, and we're trying to reduce that uncertainty through collecting data, essentially. And the risk, the risk to the payer is that they're making a bad buy, so they would like some insurance against that. So this particular study was focused on the private sector in the U.S. Josh talked about a few examples. Unfortunately, we have, a very few number of examples in the U.S. in our database. I'm told when I talk informally with people that companies are doing a lot. And the results we're going to report are from about a year and a half ago. But we see in the literature, we see people, as Kimberly said at the beginning, people wanting to be seen as first movers and innovative. So there is still tremendous interest. Josh and I have worked with companies who are trying to develop these schemes, and they're doing their due diligence. But next, I just want to talk about, really focus on the paper, which is, was published in the American Journal of Managed Care. And if you look at the paper, you'll see one of the key things is 3 figures of kind of optimistic comments, pessimistic comments, and cautious comments. So, you can find a quote to support about whatever you would think here, but you find we talk to people who had actually implemented them and say they moved on to other companies, and as part of their due diligence in developing a product, they actually consider them. We talked to people who said, I've been talking to people for years and years, consultants, and everybody talks about these, but they never seem to happen. I've also talked to people, and not just in the pharmaceutical realm, but in the medical products realm, who said, we're doing it. We're putting in coronary stents, and if they don't work, we make a payment. So there's a lot happening out there, and I guess that the fact that we have, I guess, well over 100 people on this call is testimony to the level of interest. So what I want to do is talk about this, our interviews and our survey. And the interview guide is a semi-structured interview guide is in the back of the paper if you're interested in that. And then after we'd done that, again, we had these kind of equivocal mixed results, and we wanted to do a survey to try to we did a simple survey, not nationally representative, but it did identify some consistent themes that were consistent with our interviews to sort of pick out some of the issues. So with that, I'll try to move through some of these themes. Again, we did 14 one-hour interviews with a mix of manufacturers, payers, and experts. And as Josh said, there's mixed interest in these outcomes deals. People are certainly doing kind of financial deals, and I would say particularly, in Europe, and I want to mention that just because there is another element of this, and say Eastern Europe, and we don't have a lot of those in our database, but it's clear that that's going on. In the European context, it's much more of it provides a way to do differential pricing to get around some of the external reference pricing and parallel trade issues in Europe. So there's a lot of that going on, but it's also, in the U.S., essentially we have a kind of differential pricing in that companies can charge differential rebates, can reach agreements with manufacturers and payers can reach agreements about discounts and rebates. So in a sense, that is kind of a financial agreement already. Now people are moving on to saying, can we measure outcomes and what are the issues? And what we wanted to do in these interviews to try to understand those, what were the barriers in the U.S. given the limited numbers that we've seen. And the reason this is important is for us, the broader context is, I think we all realize that, as researchers maybe, or even as patients, we would like to know what works best, and what works in the real world. So we all have a stake in finding that out, and at least in the U.S. with our decentralized system, companies, manufacturers, and others have limited incentives. There are what economists would call free rider problems. If you spend a lot of money and then release the information, others will benefit from the information, and you won't get the full benefit. So, that's kind of the fundamental limitation of kind of the private sector orientation. Now, Josh has talked about coverage with evidence development in CMS in the U.S., which is quite similar to the Swedish system, which has a great registry system. They're able to kind of, because they have great registries, actually measure what happens in a wide range of things and then renegotiate prices, which is one way to do things. But here we're really trying to focus on what could be done in the U.S. private sector, what is being done and what could be done if we thought that it was a good idea to promote these. Now, one of the key themes in this is this next slide on logistics. Logistics is a big issue, okay? It's clear that payers only have limited bandwidth to do a few outcomes-based agreements. Payers are willing to do multiple agreements with companies for competing products. So we found some people who would say, well, I would be willing to do that, but at the same time you could see that you could understand that manufacturers might be able to obtain a first mover advantage by reaching an agreement before competitors. So it's kind of mixed incentive from both sides. Obviously, from the logistics side, you need to be able to measure the key outcome that is the source of the uncertainty. So it could be HbA1c impact in the Januvia example. It could be the fracture rate in the fractures in the Actonel example, and so on. So, and those need to be measured in a reasonably short time frame. So most of what we heard was companies were thinking, or manufacturers and payers were thinking of a reasonable range is a 2 to 4 year agreement. We have extensive contracting agreements in the United States, so these would be kind of modified contracting agreements that would include options to opt out at some point. And we sort of talked about that some. The data collection would typically be the responsibility of the payer, especially if you're thinking of an administrative claims database. And I think that's certainly one of the ways that, and maybe the most common way that people are thinking about this in the U.S. Next slide, please. Now, you could ask, well, what are the reasons to use these? We've hinted at some of these. We've touched on some of these. And it really does depend on the product, the disease area, and whether there's the data infrastructure to measure an outcome. Okay, so we've identified area, the diabetes area. We've identified the fracture area. So in Europe, certainly, as Josh said, both in Europe and the U.S. oncology, where you can measure things like disease progression, has been, in the near term, is something that's an area that's been popular. Okay, so again, the basic motivation for the manufacturer is to differentiate their product and demonstrate the value. We're mostly talking about these for newly launched products. It's a case where the trials have provided some limited evidence, but there some evidence of clinical benefit. But the trials are primarily focused on efficacy issues, and what we're concerned here is about effectiveness in the real world. So the idea is to develop and demonstrate arguments for comparative effectiveness. Now, we have a nice quote here from one of the payers saying, if somebody can help reduce the risk, take some of the variability out of the equation, or can actually help you manage some of the medical costs, that's very attractive, and that's more attractive than just getting a discount. It allows us to get experience using the medication for our members and so on. Okay, so that, I think that in a sum really sums up why this would be of interest to payers to learn. Okay, next slide, please. In terms of what works, obviously a key thing is to have data infrastructure that allows measurement of the variables that you care about. So certainly easier to measure outcomes for drugs that are administered in some settings, hospital settings versus others. Complex settings, complex outcomes would require an active provider measurement. I would like to mention, and Josh pointed this out, that Italy is the largest, has the largest number of these agreements in the world. And what Italy has done is fascinating. They have essentially constructed a web-based overlay on their healthcare system, so that if a prescriber is going to be reimbursed for prescribing a medicine, they need to log into that system and enter that data. Now, the downside is that's a burden on the prescriber. The plus side is it's not relying directly on the medical records or having adequate electronic medical records to measure clinical outcomes. So with that approach, that you can sort of rapidly institute a system. Now, at the same time, to this point, Italy has done a good job of implementing that system, but they have not collected nor promulgated the results of and they've been criticized for this, of those studies. So they're under pressure to do that. So again, the second bullet here, the clinical outcomes are most successful when there's robust infrastructure. That's key. Okay, and again, when we think of U.S. Pharmaceutical industry, we're basically thinking of using a claims database to measure, if you can measure something, and reaching an agreement between the manufacturer and the payer on what would be measured. And what you would imagine is they would presumably do some analysis ahead of time, look at existing patterns, so that both of them are comfortable with how they're going to measure it and what they would be measuring. So they should be able to predict the outcomes of the agreement. And also this key issue is what level of compliance is required, because we know that the manufacturers obviously can't necessarily control compliance. Interesting thing about the Januvia example was their desire, that they built in a compliance incentive in that. But as you know, compliance is a big real-world issue. And in fact, although it's not private sector, the U.S. The 5-star system for Medicare was mentioned in the interviews as one of the areas as a kind of outcomes-based agreement. Now, here you find the quote at the bottom. You find kind of a critic from Europe saying there are very few disease areas where these make sense. You need a severe acute condition. So we get both sides of the views. Next slide, please. What doesn't work? Well, what's not going to work is having multiple products in a single agreement. That increases the administrative complexity. There's an issue of what can you measure through the pharmacy benefit managers' access to claims data versus non-pharmaceutical expenditures. I mean, Josh talked about the example, the Actonel example, where there were payments for fractures. I think the key thing there to note was no one agreed to actually reimburse for the reported costs or charges in the system. It makes much more sense in a U.S. setting to specify ex ante some level of amount, some payment for some particular adjudicated event. Okay, again, just in general, this third bullet basically says these agreements are risky for manufacturers because they have to have a lot of confidence in their product, and if there are other factors in the healthcare system that they can't control, that's an issue. Okay, and the other thing is they're going to have, in a U.S. private sector arrangement, they're going to have to reach a kind of a contract, an agreement, much like they do currently for just general contract agreements. And so they have to trust each other enough to do that, and they have to be able to write that contract. Now, they have a lot of experience at writing contracts now, so you would like to think that would provide a good basis for that. Now, just at the bottom of that slide, I won't read the whole quote, but I will say that there is that basically to highlight the point that there is, with enough time, that they should be able to make these agreements reasonable. So we have a person saying that give us more time, we should be able to overcome some of the barriers and implement these agreements. So the last slide around the key themes, the next slide, and Kimberly touched on some of this. And this is basically, there are opportunities, it's clear in the U.S. for private sector. It's clear there's a lot of discussion going on. With the movement toward accountable care organizations and thinking about value and thinking about risk sharing, that may provide kind of a culture of risk sharing agreements that could lead to further discussion around these agreements. Okay, Medicaid best price is an issue that comes up. It was raised. Certainly, I guess our take on it was, well, you should be able to write an agreement to sort of limit the impact of Medicaid best price so that you wouldn't be getting discounts that would unexpectedly affect that. But certainly it's something on people's minds. And again, we have a very decentralized system with multiple payers, multiple manufacturers, and these agreements are most likely going to be usable with large payers who have a significant amount of market share because there are substantial costs in setting these up. Now, one of our people said this could evolve in an interesting way if, in fact, systems of care reform, change, and if the ACO concept catches on, as I said, that could provide kind of a substrate for this. Now, let me move on. So those are the key themes from the interviews. Again, a mixed, optimistic, pessimistic, and some cautious comments. We also pulled out the barriers to use for these, and we have, in the next two slides, I'm looking at the clock, I think we're still okay, but we have potential barriers to use and RSA use in the U.S. First is the significant additional effort required to execute these. Issues like identifying meaningful outcomes, measure real-world outcomes, the data infrastructure, the difficulty in reaching the contractual agreement. Next slide. Mentioned some people were concerned about Medicaid best price. There are concerns about patient selection, and that if a payer becomes too visible as the payer that covers disease condition X, they don't necessarily want to draw all the patients into their plan. Again, our fragmented system and switching makes it difficult for people to feel that they're controlling the long-term outcomes. They really need to be able to assess the risk up front. Again, they need to do that through some data analysis. Again, lack of control of how the product will be used and just the significant resources and costs. Now, we mentioned in the paper that we've got a follow-up survey of 16 people, some of whom were initial members of the interviews, and basically in the next slide, you can see that the most significant barrier that these folks cited was the significant additional effort to set this up. Data infrastructure is right up there, Medicaid best price, significant resources, and so on. So some of the other things, like lack of control, fragmented, were not seen as the major barriers. So having data systems that can kind of minimize the cost of setting these up would be critical. So let me turn to the next slide and wrap this up. I'll have to wrap up pretty quickly here. I just want to say, so again, there's growing interest in the U.S. A number of agreements is still small, but we're very interested. I wanted to mention at the outset, you have our email addresses at the end, so feel free to please send us your comments and questions, and we're anticipating further interviews and research, so we'd be happy to talk with you. Now, in the interest of time, I won't go through all of the details in the next few slides, which is then the next slide is about a good research practices task force that we did at ISPOR. Again, this was a couple of years ago now, and just pulling out a few of the conclusions and findings. We saw that these agreements are an understandable response to market forces. This is on the next slide. And this really goes back to this pressure to demonstrate value. On the next slide, we highlight the uncertainties and that good governance is important. And then finally, on the last slide in ISPOR, we're really looking at this real-world evidence of the global public good. As potential patients, we would all benefit from having access to this. So we're very interested to have the people who do these studies disseminate the results. And clearly, with free rider issues in a fragmented market, there's a limited incentive. So we should think of ways to try to incentivize parties to engage in risk-sharing agreements. Again, to this point, as Josh has pointed out, there was a dearth of evaluation. So let me stop there and turn it to someone who doesn't live in the ivory tower like we do, Ed Fazzala, to tell us what's happening in his world. Thank you, Ed.
Lou, thank you very much, and I'd like to take a few minutes and basically go through some of the points that Josh and Lou have already brought out about the study, but also importantly about how payers may be viewing some of the elements of these performance-based contracts. Next slide, please. So there's a couple of questions about why do them in the first place. That is, what issues or questions will be addressed. And there's a number of areas that have already been pointed out, areas of uncertainty, which I'll go into in a little bit more detail, but that's certainly an important place. I mean, we know everything about a medicine and how it's going to be used and who it's going to work for, then there's really no reason to do a risk-based contract, but instead what you do is you sit down and create a model to understand, all of those things we know. But there's always a great deal of uncertainty in many things, and this can be improved over time. And also the place in therapy can sometimes be a question mark in terms of, is this a first or second line therapy, and a risk-sharing arrangement sometimes, especially, say, managed market entry and that sort of thing, can be helpful there. And then the primary barriers have already come up, and I want to spend a little bit of time on the cost of implementing, the transaction costs, issues around data, and just how big is the opportunity. Next slide, please. So addressing uncertainty really makes a lot of sense. There's a lot of different uncertainties, and some of these are more germane in certain disease states or with certain medications than in others. Long-term safety might be an issue in some, and oftentimes it's not the reason for doing a particular contract, but it certainly could be one of the components. Outcomes is much more likely to be a question. So a drug may be approved, for example, on an intermediate outcome, reduction in blood pressure, or some other measurement, but the real question is there a long-term outcome impact for patients in terms of reducing stroke or some other bad event that you want to limit. It may also be unknown what is the effect on the individual patient. That is, there might be a drug that works spectacularly well for 20% of the population, and for 80% not so spectacular, and maybe doesn't work at all. And until you've come up with a way of identifying those patients up front, then you have to deal with the fact that there's going to be an awful lot of patients who don't really benefit from the medication. Changes in behavior are an interesting set of questions, and we see contracts go in different directions here. So adherence is generally the biggest thing, because there's oftentimes when a new medication is introduced into the marketplace, there may be an assertion that giving it once a week leads to better adherence than giving it every day, or giving it once a day is better than twice a day. Or that the administration of it is easier. It's better to have a pill than an injection. It's better to use a pen than to use a needle. So there's a lot of different opportunities here for contracting around adherence. And in that case, that would be a contract where the manufacturer is in some sense responsible for adherence to the medication because that's supposed to be the advantage of the medication. In other contracts, we see that it's really not adherence that we're trying to improve, but outcomes for patients who are adherent. And many times then the adherence component is given over to the payer to take responsibility and to make sure that enough patients take the medication that those patients can be included in the calculations for the contract. And then there may also be some questions about the impact on utilization and cost. That is, the utilization of this medicine will result in certain cost offsets, reduce utilization somewhere else, and in some cases then we see that the contract takes those things into account, and indeed those may be the outcomes, so reduction in cost, total cost of care, and those sort of things. And those calculations can sometimes be complex. A reduction over what period of time, what's the comparison group. Historical comparisons are difficult in economics because costs go up every year, but not necessarily the same amount every year. Next slide, please. So what are some potential solutions to some of the issues? So transaction costs are pretty high for some of these, and so creation of, say, what I'm terming here reusable platforms, which basically is data capture and collection, as well as reporting of the data, establishment of sort of standardized contracts and things like that. So years ago, we had to come up with ways of dealing with rebates. And have rebate reporting and auditable rebate systems and those sorts of things. Eventually, it made rebating much easier and a more attractive option for both the pharmaceutical firm and the payer. We need to consider what would be some kind of reusable platforms for outcomes-based contracts in order to allow them to move ahead. It's been mentioned that some of these contracts would be better if they involve providers, or perhaps they're with providers that are also taking risk. But certainly it's important to note that the providers oftentimes own some of the most important data. A payer mostly knows about claims. So we might, for example, know that a patient didn't have a fracture because we don't have a claim, because we can all agree that almost all fractures are going to generate claims. Same with admissions for heart attack or stroke or something like that. But there are other important outcomes that we might be interested in: weight loss, reduction in hemoglobin A1C, which is much more difficult to obtain. And so providers being part of this activity and that being considered in these so-called reusable platforms would be extremely helpful in implementing these kinds of contracts. Medicaid best price was mentioned already, and I would like to point out that one of the issues we have is that sometimes the Medicaid best price is so close to the price that would normally be calculated after rebate that there's no point in doing a risk-based contract, because you can't really get the price of the pharmaceutical down any lower if the outcome is not good. Especially if the pharmaceutical firm has gone at risk, as was mentioned here, say for medical costs resulting from the patient not receiving the benefit of the pharmaceutical. Those costs can be pretty steep, and many times it means that you have to write such a limit into the contract that the contract is not that desirable to the payer. So it's a policy issue to address whether Medicaid best price would somehow be avoided by the appropriate kind of risk-based contract. And we don't know that yet, but there are certainly things going on in Washington to ask this question. And then locus of control is an interesting problem, and that is, what really controls the outcome for the patient? Is it just the pharmaceutical? Well, probably not. I mean, it has to do with adherence and persistence, which is something that doctors and patients participate in, and certainly the proper use and dosing, that is finding the right patients and making sure that they're using the drug in the right way, that doctors are writing the right dose, and that sort of thing. And one way to control all of these things is basically to just exclude patients who don't meet all of the criteria. The problem is that you can end up excluding an awful lot of folks and therefore not making the contract particularly worthwhile. And so one thing here is to put in rewards for whichever party is responsible for appropriate use or adherence in order to be sure that more patients are participating in the system. Next slide, please. And so where do we think we may be heading with this is looking at sort of the broad view of patients and looking at overall at their outcomes, looking overall at the costs and improvements in care, and certainly involving providers here. And so we have to have approaches that meet the needs of all four participants in the process, which is the patient, the provider, payers, and the pharmaceutical firms. And we're going to have to create partnerships, sometimes more than two-way partnerships, to make these work. There'll have to be enough money on the table to make a contract worthwhile, and we are all going to need to share data in order to make these really worthwhile. And I totally agree with the assertion made by Lou that the data generated here is a public good, and we should strive to get the data into some form and format where it can be accessed and used by all. I believe that's my last slide. Thank you.
Great. Thank you so much. Now we're going to move on to the question and answer portion of our webinar. We've been getting lots of questions. We did get a variety of questions about the specific agreements that we discussed at the beginning of the webinar. Some very specific questions around what type of data does the payer share with the manufacturer, who owns the data, questions about the discounts. It was beyond the scope of this work to gather that very specific contracting type of information. So I can't answer those questions or ask our panelists to answer those questions. But one general question that several folks asked is why some of these arrangements give a discount for a product that doesn't work well, and some of them give a discount for a product that does work well, since they seem to be opposite scenarios. So I'm going to pose that question to Josh Carlson and see what the answer is.
Sure, thanks, Kimberly. So essentially, every contract is unique. The way that the Januvia one was set up was essentially they put that out there as an incentive to try and get the payer to have basically motivated to try and improve adherence, but also bet on their drug. Because the discount was for looked at all patients and whether all of, if their A1C values improved on average in aggregate, not just those on their own product, if Merck essentially had a belief in their product being the best, then they're setting that up as a way for the payer to perhaps get more patients on that product, but also try and increase adherence overall to meet that. And with increased adherence, you get increased prescriptions, so there's a benefit to the manufacturer in terms of more volume in that scenario. And if they shift more patients to their product, there's a benefit there. So in that scenario, it's a little. I agree that it's an interesting and unique aspect of it, but they're trying to set up an incentive for the payer. Now, on the other side of things, if you just think of that outcome as being an area of uncertainty, you want to make sure that you essentially are trying to address that uncertainty. So where you see a discount, if you don't achieve a certain outcome, it's primarily because you're worried about not achieving that and there's a certain uncertainty. But the key component is every one of these agreements is unique to some degree, and it's about trying to come to an agreement that works for both sides. So you can see how you can use these as levers to meet whatever is your particular area of need.
I'm going to lump a few questions together. Folks are wondering to what extent there are opportunities to work with accountable care organizations, health insurance exchanges. Is there a role for employers in this space? And we've primarily been talking about a relationship between a payer and a manufacturer, but there are a lot of other players in this space. And I pose this to all of our panelists. Do you have thoughts on roles for some of those other groups?
Well, let me just make a quick comment and then turn it over to Ed, who I think brought this point out, Kimberly. This is Lou again. But first I want to just, I wanted to underscore Ed's point about reusable platforms. I think that's, in terms of contracts, in terms of data system, those are key things to moving this forward. And certainly there are more parties involved, as he emphasized, the provider has an important role. So let me just turn it over to Ed to speak more broadly about that issue.
Yeah, I think there is room here for a number of folks, and of course you can't have too many people working on any one contract, but I think it may depend on the situation in terms of what does the health plan look like, is it self-funded or fully insured, and how active a role does a particular employer take. So employers can certainly have a role here. Self-insured employers manage their own benefits in the sense of they tell the health plan what it is that they're looking to do, and the health plan helps them to create something around that. And if there are particular areas of concern to the self-insured, that I don't want to cover this if it's not really going to result in some sort of improvement or something like that, then this can be an area that helps out. And we need to recall that for most self-insured, if they sign on to the broader formulary and formulary management that a PBM or a health plan is doing for them, then they participate in the rebates. So if these are contracts that are going to change the rebate, then the employer may want to have some say in how the whole thing works out, and indeed they may do something that helps encourage this program, which it depends on what the medicine is, what it's supposed to be addressing, and that sort of thing. But employers can definitely be an important helper here. Yeah, I agree. Providers are certainly extremely important. And even providers who aren't at risk may indeed be partners in some way in making these things work out. So it may be, for example, that you simply are working with providers to make sure that they understand the proper use of a new medication. This is properly the role of a pharmaceutical firm, but it might be that maybe more intensive effort is put into a particular area or a particular type of specialist in order to help out.
Great, thank you. We are nearing the end of our hour, so I'm going to pose one final two-part question to each of the panelists, and maybe Lou, you could answer first, and then Josh, and then Ed. First part, do you think there should be more risk-sharing agreements in the United States? And if so, what's perhaps one of the most important things that we could do to have a more conducive environment to that?
Yeah, in the interest of time, first I just want to thank you, Kimberly and Bobby Du Bois at NBC for your support in all of this. We really appreciate that. I'm in favor of more agreements. I think we need more real-world evidence generally. This is a public good, and I think we need to work to incentivize parties to reach these agreements. So maybe there is some role for public activity that we need to investigate, but certainly at the very minimum, helping to develop some reusable platforms that could be shared across the parties might be helpful. So we'll stop there.
Yeah, I'll just comment, I think so as well. I don't think that they're going to be the right answer for all arrangements, but I do think that there is a role for them, and I would like to see more moving forward. I also would like to echo my thanks to NBC and everyone for joining today. One thing I think that could help to do that would be to have essentially an organization, perhaps a nonprofit or something like that, or at least something of that nature to facilitate the arbitration of these agreements. That is a third-party entity that would sort of allow for data sharing in an environment that all parties could agree to, would be one thing.
And I think that we should see more of these. Certainly, as mentioned, it's not the cure for everything that we need, but there are certainly areas where generating more evidence is really going to be helpful in understanding payment, and also where the value of a pharmaceutical needs to be more firmly established, especially now that we have more rapid pathways for development. There's generally questions that are sort of left and I think that that's an opportunity for contracting, but I agree. I think that we need to find a way to reduce the transaction costs, and having third parties and other sorts of folks to help with the contracting and data aggregation is certainly important.
Excellent. Thank you, Lou, Josh, Ed, for joining us today and sharing your insights on risk-sharing agreements. We will be archiving the webinar and making it available, and we've also had questions about the slides. So what we may do in this situation is actually put the slides up early before we actually get the full archive available. So thank you very much for joining us today.